Sleep is blissful and healing to mind and body, but sleep disorders are destructive to health and happiness. Stay with us while neuropsychiatrist Dr. Saad Shakir teaches us what causes them and what can be done about them. I'm so happy that Dr. Shakir has returned to educate us on another important subject. Would you please tell us about your leadership positions at hospitals and other advisory positions?
So I've been involved in the past as chairman of psychiatry at El Camino Hospital. For many years I served at Stanford clinical faculty up to associate clinical professor, and I sit on several national and international advisory boards.
Okay, well, we have a lot to cover. We all know that our neighbor might have a barking dog. It keeps us awake all night. We get up the next day. We're upset, we're angry, and we don't feel well. But we get over it. But people who have chronic sleep deprivations, how does that impact their health?
Great. I think you already started my talk by, I made sure I had a good night's sleep last night to be here with you. And you identified the barking dog. So all of us have an occasional disturbed night's sleep. If you have an exam tomorrow or a barking dog in the neighborhood, the room is too hot, too cold. These are transient insomnias. The ones we worry about are what's called the chronic insomnias, where someone regularly has disturbance of sleep, either difficulty falling asleep, staying asleep, waking up too early, or disturbed behavior through sleep. So those are all lumped together as sleep disorders.
And how does it affect our health and our minds, actually?
So I start by telling you why we sleep.
Mm-hmm.
Sleep is part of survival. We spend at least 1/3 of our life sleeping. We need it to rejuvenate. Sleep is healing, is important for recovery. It's important to rejuvenate, it's important to be able to function next day, and there are major consequences if we have disturbance in quality or quantity of sleep. And if it's chronic, it can lead to cumulative sleep deprivation and many neuropsychiatric and medical consequences, which I will be glad to elaborate later on.
How does, say, somebody who can sleep 5 to 6 hours, how does that compare to people who maybe sleep 2 hours, get up to take some medicine, sleep 2 more hours? In other words, they're getting incremental sleep, maybe 8 hours, but it's broken. Which is harder on the body? A short 5 hours or all these chopped up increments?
So let me backtrack and maybe define what normal sleep is, and then we can get into abnormal sleep. Normal sleep quantity is thought to be anywhere from 6 to 10 hours. Based on the American Academy of Sleep Medicine, they did a survey and they found out the average sleep in the US for adults is during the week is about 6.5 hours a night, and on weekend an hour more, 7.5. And if you look at that compared to 50 or 100 years ago, it has diminished. And part of that is because people are more stressed, working more, longer hours, but that's the normal sleep quantity. Quality is restful sleep. And we have 2 types of sleep, rapid eye movement sleep and non-rapid eye movement sleep. So a good night includes 6 to 10 hours in that range of a combination of stage 1, 2, and 3 of non-rapid eye movement sleep. Stage 3 is what's called delta wave sleep, which is restful, restorative sleep, and normally in adults, about average adults, 20%, 15 to 20% of the night has to include delta wave sleep. And then we have non-REM sleep, REM sleep, rapid eye movement. During that time, if we're observing somebody in the lab, the eyes is moving a lot. That's when dream cycles happen. And that's about 15-20% of the night. So if you have a normal sleep, you have normal quantity and quality.
What about sleep apnea?
So sleep disorders, let me talk about that. Sleep apnea is a primary sleep disorder. So let me tell you, so if you survey the US population, about 20% of the US population has some form of a sleep disorder. So if we were to investigate it, 80% of those who do have a sleep disorder, it's usually what's called a secondary insomnia. That could be secondary to a medical condition. For example, if you have someone with chronic obstructive pulmonary disease where they're not getting enough oxygen, or somebody with heart failure, somebody with chronic pain. So that could be the primary reason they're not sleeping. Or more likely, secondary to neuropsychiatric disorders. And that can include the gamut of depression, anxiety, bipolar, stress reaction, marital discord, PTSD. So those are probably the commonest contributors to insomnia. 20% of the population that does not sleep well has what's called a primary sleep disorder. Among the primary sleep disorder, the commonest is obstructive sleep apnea. And that can happen at any age. In older people, the typical age is midlife and associated with obesity, diabetes, hypertension. But in younger people, it could happen as young as a baby if they have large tonsils or adenoids, or if they have narrow respiratory pathways. So that blocks oxygen going to the brain. And that type of disorder needs to be treated medically. There are a variety of treatments available for sleep apnea. The common one is what's called CPAP machine, or sometimes BiPAP machine, where a machine delivers oxygen at high pressure to overcome the blockage if it's related to a blockage in the airways. Sometimes surgery is done, but that's not the mainstream. That's only if the anatomy is disturbed and somebody needs an enlargement or moving of the jaw. The majority of sleep apnea is treated with a CPAP machine that overcomes the blockage. There are other primary sleep disorders.
Restless legs.
Restless leg syndrome, periodic leg movement.
What causes that?
So we don't know what causes that, but usually a person has hyperactivity in the feet, and they have a creeping or crawling sensation. I jokingly say it's the soccer player who only plays soccer in their sleep, and usually it's their bed partner who's most impacted by that, because they're kicking and thrashing and their sheets are messed up. So we don't know what causes that, but oftentimes it is treated with medications that work for Parkinson's disease. So there could be a correlationship there. There are also what's called parasomnias, REM sleep disturbances.
That's what I wanted to ask you about, the REM sleep disturbance. That's kind of horrifying, isn't it?
Doesn't have to be. It could be normal for certain stages. Rapid eye movement sleep disturbances. The commonest actually is diminished REM sleep, which can manifest with sleep deprivation. However, there are some behavioral things that happen during REM disturbance.
That's what I thought was kind of scary.
That can be scary.
What happened? What could happen?
Well, basically, it's like waking up and doing things and they don't remember it. In the middle of the sleep cycle, I've had patients who say, my God, I found out that there were wrappers on the floor, I was eating at night. Common one is eating disorder in the middle of REM cycle. But it also could manifest with thrashing, agitation, muscle movement. It could actually have a psychological basis if someone has major stress during the day and they're not really venting it or exercising enough. It could be coming out that way to ventilate the agitation and the anxiety. I always describe it as a back burner phenomena. If you clutter too much on it, it's going to overflow. And when we're asleep, we don't have the sensor of the higher cortex of the brain. So people can manifest it in uninhibited ways, including rage, anger, sometimes even violence, doing things like that. Sure.
Some people claim they don't dream, and others dream all the time. Are they not Are they really dreaming and don't know it, or do they not dream?
So dreams happen whenever there is REM cycles. So the majority of people do have rapid eye movement dream. However, if they are not in a deep state of sleep, they do not remember their dreams. So oftentimes, if there is shallow delta wave sleep. Delta wave sleep is the one I mentioned earlier. That's the deep restorative sleep. That's when you feel charged and ready for action. And if you don't have 20% of the night in delta wave sleep, let's say I had a patient the other day who is having less than 1% of the night in delta wave sleep. That person is going to have major difficulties because he doesn't remember his dreams, because he's not getting into delta wave sleep. So you can have cumulative sleep deprivation. So everybody has dreams. Not everybody remembers their dream. Now, if somebody, also people tell you, I never sleep. In reality, if you put them in a sleep lab, they are sleeping, but they're not getting. A lot of people with stress have stage 2 sleep, where they are asleep, but it's not deep restorative. They can hear the noises around them, so that they're not really recharging their battery. So that's a sleep disorder also. So we try to deepen it with medical and non-medical interventions, which we can talk about.
I wanted to ask about night terrors.
Night terrors are common in children.
What are they?
So basically, it's similar to having an anxiety attack in your sleep. That's one way to look at it. And kids can manifest it as a normal stage in development, especially around 5, 6, and 7. They can run to their parents' room and stay with them so it's waking up in the middle of the night and not remembering it, with usually a bad dream or a thought that their life is in danger. So that's why it's called night terror. If it persists, we worry about it, and then we do a sleep study on it.
Now, sleepwalking and sleep talking, how do they fit into all this?
So these happen all during REM cycles. So if you observe, I mean, even everyday life, I remember, like when I was an intern, I would be awakened by a phone call, let's say, from the hospital. And I didn't remember anything. And the nurse said, oh, sorry to wake you up at 3 a.m. Thank you for the feedback. And I didn't remember it. And I was coherent and cognizant. So I started training myself by putting a pad and pen next to my bed, because I need to know and document that. So if you wake up in the middle of the REM cycle, you might or might not remember that you woke up, and you can have conversations that you don't remember. So it's a dissociative state. It's not related to the mainstream of consciousness. But that's what happens. Okay. People have awakening and they don't remember what they do in it.
So they can walk or talk. It's not, you don't know how it's going to present itself then.
Well, sleepwalking is common. Parents come and sometimes they're really worried. If it's a very young child and they live on the second floor, they worry they might fall. But what's interesting, most people who sleepwalk do it as if they're awake and aware. They don't really run into danger. Their eyes might be open, and you might tell them, you're awake and you're walking. He says, no, I don't remember that. So it is an altered state of consciousness manifesting with walking. So you have to make sure that they don't do anything harmful during their sleepwalking.
What about sleep paralysis?
Sleep paralysis is quite common, actually. So if you look at, there is an area of the brain called reticular formation. That's the alertness awake center of the brain. So if you're startled by a noise or any external event, you might be aware of the noise and you wake up. But your motor center, which is what controls movement, is not awake. So sleep paralysis is a dissociation between your alertness center and your motor center, which is the one responsible for movement. So it could be very transient. That's normal phenomena. If it lasts more than a second or so, we worry about it. But most of the time, it's a non-significant phenomena. Again, if you're sleep deprived, I know it's happened to me when I've been really tired as an intern or not enough sleep, and all of a sudden I'm awakened by noise. I wake up and my body can't move, but within a second it can move. So there's a delayed response of the motor center. So that's sleep paralysis.
If it goes on for a length of time, then
it should be investigated.
Maybe it seems like it's a long time, but to the point where somebody is trying to call for help, I can't move or whatever, and that goes on for quite a little while, they feel like it's going on a long time. That's something a little bit different than?
In 2016, I think anybody having a persistence of any sleep disorder, it should be investigated. We have a lot of expertise in sleep medicine now. We can do a sleep study, an observed sleep study in the lab, or we have even ambulatory machines now that you can take home and study. So we really should investigate. Not just the sleep, but sometimes there are medical reasons people are waking up. So we should, or psychiatric reasons. So we should definitely do a full investigation if there's a persistence of a symptom like that.
And then the reverse is the narcolepsy. How does that fit into all that?
Narcolepsy is a very concerning sleep disorder, because these are the people who have cataplexy and can fall asleep during the day without a warning. So if they're driving, they could be in a danger. This is actually, there was a TV show a while back where Stanford Sleep Lab did an experiment on Doberman Pinscher's dogs. And when they have narcolepsy, they really collapse and they're unconscious. So narcolepsy is falling asleep during the day, unprovoked, and going into REM cycle without the 3 stages of non-REM. And it's studied. So if somebody suspects narcolepsy, there is a special polysomnogram sleep study called MSLT, multiple sleep latency tracing. That's done during the day, and the clue is abnormal movement in the EEG pattern, and they fall asleep within a few seconds into the dream cycle, the REM cycle, without going through. Normally, if you track a normal person who is in a sleep lab, it takes at least 60 to 90 minutes to get into a rapid eye movement cycle. That's normal. So you go stage 1, which lasts a few minutes up to 20 minutes. Stage 2 is 50% of the night, roughly. And that's when you're asleep, but you're not in deep sleep. Then there's delta wave sleep, which is about 20% of the night. And then you have your first REM cycle, rapid eye movement. So it takes about 90 minutes to get to REM cycle. In narcolepsy, within a minute they can be in a REM cycle. And that's really the danger, because if they're driving a car or machinery, they can have major accidents. The good news, it's correctable and treatable now. One more thing, on an average night for an adult, there are about 3 to 4 cycles of sleep, so REM cycles, and they happen about every 90 to 120 minutes.
Now, on the narcolepsy, there are different levels of it, right? I mean, it can happen just on occasion, or it can happen daily, and sometimes it can happen so fast that maybe people wonder what happened. Is that the case?
Well, narcolepsy, by definition, is the one that happens fast. There is another...
But I mean, they stay out. What I mean is they can go to sleep and wake up really fast, or they stay asleep a long time.
Either, depending on the individual. But there's another phenomenon called excessive daytime sedation, EDS. Those are the people who are like narcolepsy, but don't really go through the cataplexy and the paralysis. They're really, I mean, you see them in a meeting and they doze off. That's not quite as severe as narcolepsy. And these are the ones who usually use excessive caffeine or other stimulants to stay awake. So that's excessive daytime sedation.
That's not anything like a petit mal, is it? I mean, it'd be hard to determine whether it's a little narcolepsy, or what was the last one you just said?
Excessive daytime sedation, EDS.
Okay. And petit mal, because they're all kind of have the same symptom.
So you're bringing a whole other spectrum here,
right,
which is seizure disorders.
Yeah.
There is a type, there's a grand mal seizure and petit mal seizure. Petit mal seizure are stages of absences. So it's not really falling asleep. An example, if let's say you're talking to me and I have petit mal seizure, I'm going to demonstrate.
Yeah.
What did you say?
Oh, okay.
So it's a brief absence.
Oh, it's a pause rather
It's a pause.
Okay.
You don't remember it. There's but your eyes are open, but they're not consciously connected to the conversation. That's a type of seizure disorder. It's treated by neurologists with anti-seizure medications. That's very different from.
Do they all the disturbances come from the same area of the brain?
No.
They don't.
No.
Okay.
if you have, so there's also sleep-wake cycle disturbances. A common phenomena is jet lag. So when people travel, there's an area, one of the main areas that controls sleep is the anterior hypothalamus of the brain, which is right behind the eyes. There's an area called suprachiasmatic nucleus. And there's a pineal gland that is a little behind. Those areas are very crucial in sleep-wake cycles. And they're regulated by different chemicals, including orexin, serotonin, dopamine. Now, this is the fall season, right? So seasonal affective disorder are very common in people who have sleep disturbances. So in the winter, there's a shift in melatonin. People sleep too much or develop mood disorder. A lot of it is related to light. Light is an important aspect of regulating sleep cycles. So when you have jet lag, basically it's related to the brain being fooled by not getting enough light, and whether you're in a dark zone or a light zone, it kind of messes things up. So there are ways to treat that by resetting the brain cycle.
Do people who work, like I've read a long time ago that people who work split shifts, they might sleep 3 or 4 hours and go to work and then come home and sleep a few more and go back. Maybe they have 2 jobs or some kind of a swing shift. They're more apt to commit suicide than people who have regular day jobs and sleep at night. And is there anything to that?
I would be very careful in that statement.
Okay.
Now. So let me kind of break it down here. There are what's called circadian clocks. We each have a clock inside our brain that works a certain way. Some people have a 24-hour clock. Some people have a 23. Some people have a 26, which means they sleep differently from the world around them. The spectrum of bipolar disorders, which we talked about last time, a lot of times the internal clock is set differently from the world around them, where they stay up at night and sleep during the day. What you're talking about suicide is the cumulative sleep deprivation.
That they're not getting their REMs.
They're not getting adequate quality and quantity
Mm-hmm.
sleep. It's not related to, so any person can develop that. And, we know the risks. We talked about it last time with bipolar. There is a higher risk of suicide in bipolar. So if you combine that with a sleep disturbance, you have a double whammy here, and you can have suicide. But it does not really apply to the whole population. Other than sleep deprivation, cumulatively is not good for anyone. And you can have all kinds of syndromes: fatigue, irritability, psychosis. Years ago, when I worked in an emergency room, I've seen people who come in after a week of not sleeping, and they are psychotic. Sometimes they can be psychotic in the emergency room, and the emergency room doctor says, "Oh, they are schizophrenic." I say, no. This could be cumulative sleep deprivation. You give them sleeping medication 1-2 nights, and they're smiling and doing well. So you have to really fix sleep because you can have consequences.
Well, just for the average person now who doesn't have a disorder, how do we get just a nice good night's sleep where we can fall asleep easily and stay asleep?
That is a wonderful question. I thought you might never ask me that. So let me kind of couch it by saying we call that good sleep hygiene. So let me define for you what is good sleep hygiene. So let's start with your daytime activities. Exercise is fabulous. Exercise every day. Don't do it before bedtime, though. So avoid active exercise within 3 hours of going to bed. But daytime exercise, whatever you do, depending on your physical abilities, you could be an older person with disabilities, you can still be able to walk, let's say. So any physical activity is good for the sleep. When the time comes, having regularity with sleep is good. So set a regular sleep pattern. Obviously you can have some flexibility on weekends. You can stay an hour or two later. The sleep environment is really important. But before I get to the sleep environment, let me tell you the things, the do's and don'ts. Do not drink a lot of stimulants before you go to bed, or a lot of fluids before you go to bed. So hydration is always good, but I always say soak up with fluids through the day, but have a cutoff about 3 hours before you go to bed. Don't over, because if your bladder, there's about a 3 to 4 hour bladder response. If you load up on fluids and go to bed, that's going to wake you up. And if you have a sleep issue, you might not be able to get back to sleep. Normally, people can, over 40, wake up once or twice in the middle of the night to go to the bathroom. But if you don't observe the fluid restriction, if you use stimulants, not a good idea. The bed should be your place for rest and comfort and intimacy if you're in a relationship. You really should not use it as an office. You should not really bring your computer to the bed. You should not have loud noises in the sleep room. You should have a comfortable sleep environment. For example, if you live in a downtown area where there are sirens and all that, make sure you have some white sound machines that block those noises. Make sure you have thick curtains. If you've been to Alaska in the summer, you know what I'm talking about. Because the daylight is so long, they have very thick curtains. You have an atmosphere that's comfortable. A simple thing. Make sure your mattress is comfortable. I can't tell you how many times people will refer to us for sleep disorder. And I ask them, they say, oh, a couple that have been sleeping on the same mattress for 15 years, and it has all kind of lumps. They sometimes change it, and that fixes. So the sleep environment. Minimize noise when you're in bed. No TV. As much as you like to, don't stimulate the brain before you go to bed. The last hour before sleep, try not to do emails, whatever, mental stimulation. Reading is a double-edged sword. If you read a stimulating novel when you're in bed, not a good idea, because you're waking up your brain. If you're, reading something relaxing, better still really avoid reading. Do mindfulness, meditation, deep breathing. If you had a busy day through the day, the last hour before you go to bed, give yourself decompression time. Maybe journal. Maybe express yourself through some artwork or something. Talk things out. And then half an hour before you go to bed, or when you're in bed, just focus